What does it really mean for a physical therapist to become a primary care provider? Does it apply only to therapists practicing in rural and underserved areas? Does your state practice act need to specifically use the words primary care physical therapy? And can becoming a primary care physical therapist actually strengthen your career, increase your value, and create new financial opportunities for your practice? Well, today we are going to eliminate the misconceptions and explain why primary care physical therapy is not for a limited few. It is an opportunity for every physical therapist. This is your practice, your money, where clinical success meets financial freedom. And stay with us. Welcome to Your Practice, Your Money, where clinical success meets financial freedom. I'm your host, Dr. Dimitrios Kostopoulos. On this podcast today, we will discuss how clinical excellence, professional advancement, sound business strategy, and financial strength come together to create a better future for physical therapists, private practice owners, and the profession as a whole. Today, I want to discuss primary care physical therapy. More specifically, I want to address some major misconceptions that are unnecessarily restricting how physical therapists understand primary care practice. You see, some people believe that primary care physical therapy is primarily intended for rural or underserved areas. Well, some believe it is an opportunity available only to a small number of specially positioned physical therapists. Others believe that the physical therapist can function as a primary care provider only when the words primary care physical therapy are explicitly included in that state's Physical Therapy Practice Act. Well, let me tell you that these ideas have created confusion, hesitation, and artificial limitations, and they are absolutely missing the larger point. Primary care physical therapy is not limited by geography. It is not limited to one practice setting. It is not reserved for a small number of therapists. Primary care physical therapy represents an expanded role for the physical therapist as a first contact healthcare provider. And that opportunity is available to physical therapists everywhere. So, what primary care physical therapy really means? Let us begin by defining what we mean by primary care physical therapy. Primary care physical therapy does not mean that the physical therapist treats every disease or disease process. It does not mean that physical therapists replace all of a sudden physicians. It does not mean that physical therapists begin practicing outside the boundaries of their professional scope. But primary care physical therapy means that the physical therapist is prepared to serve as an appropriate first point of contact for the patient. When the patient enters the physical therapy office, the physical therapist must be able to determine, is this patient appropriate for physical therapy? Is the patient's complaint truly musculoskeletal or neuromuscular? Could another system or pathology be responsible for the patient's symptoms? Is additional diagnostic investigation necessary? And Does the patient require referral to a physician or another healthcare provider? And how urgently must that referral occur? That is the essence of primary care physical therapy. It is not about treating everything. It is about being prepared to evaluate the whole patient, recognize what may be occurring, determine whether physical therapy is appropriate, and guide the patient towards the next right step. So, primary care physical therapy and direct access run hand in hand. For decades, the physical therapy profession advocated for the right of patients to access physical therapists without first obtaining a physician referral. Well, that effort was critically important. But direct access is not simply a privilege. Direct access creates a major clinical responsibility. When the patient reaches the physical therapist first, the physical therapist must be prepared to function as the first contact provider. The therapist must be able to recognize whether the patient belongs in physical therapy or somewhere else in the healthcare system. That requires much more than identifying tenderness, weakness, loss of motion, or impaired function. It requires broader clinical reasoning. It requires medical screening. It requires understanding of the systemic pathology. It requires recognizing red flags. It requires understanding when a presentation does not fit the expected pattern of a musculoskeletal condition. And I have said this many times. Direct access gives physical therapists the doorway. Primary care training gives them the framework. Without that framework, direct access may simply mean that the patient enters physical therapy without a referral. But with primary care capabilities, direct access becomes something more significant. The patient enters the healthcare system through a clinician who is prepared to evaluate the problem, assess risks, initiate appropriate care, order or recommend appropriate diagnostic investigation where permitted, communicate with other healthcare professionals, and refer the patient when necessary. That is how physical therapists begin to truly establish themselves as first contact providers. The patient is more than a painful body part. A patient may enter a physical therapy office complaining of back pain. Not every case of back pain is caused by a mechanical spinal condition. A patient may report shoulder pain, but not every case of shoulder pain originates from the shoulder. A patient may complain of weakness, numbness, fatigue, dizziness, imbalance, difficulty walking, or reduced endurance. And yes, those symptoms may reflect a musculoskeletal condition, but they may also reflect neurological, cardiovascular, vascular, metabolic, infectious, oncological, or medication-related or other type of systemic conditions. And the role of the primary care physical therapist is not to independently manage every one of those conditions. The role is to recognize that the patient's presentation may extend beyond traditional musculoskeletal pathology. A therapist should be able to ask, does this clinical picture make sense? Do the history and physical examination findings match together? Are the symptoms behaving in an expected mechanical pattern? Are there unexplained constitutional symptoms? Are medications contributing to the presentation? Are there laboratory, imaging, neurological, or cardiopulmonary findings that require further attention? Does this patient I have in front of me requires an immediate referral? Well, the ability to recognize when a patient should not be treated is every bit as important as knowing how to treat the patient who belongs in physical therapy. That is an essential part of patient safety. It is also an essential part of professional credibility. So, and let me talk for a moment about another misconception. Another major misconception is that physical therapists may function in a primary care role only when their state practice act specifically includes the term primary care physical therapist. This is a major misunderstanding. Primary care physical therapy is not created merely by inserting a new title into a practice act. Many of the functions associated with primary care physical therapy are already fundamental components of physical therapy practice. Physical therapists examine patients, they evaluate movement, function, and disability, they perform systems reviews, they screen the signs and symptoms that they may indicate pathology outside the musculoskeletal system, they determine whether physical therapy is appropriate, they refer patients when necessary. They communicate with physicians and other healthcare professionals. They educate patients to help coordinate care. The specific rules, terminology, and permissible procedures may vary from state to state, and every therapist must understand the laws and regulations applicable to their jurisdiction. However, the absence of the exact words primary care physical therapy does not mean that the physical therapist is prohibited from performing the examination, screening, referral, and clinical decision-making functions that are already part of responsible physical therapy practice. We must be very careful not to impose restrictions upon ourselves that the law has not imposed. During our recent discussion about the primary care physical therapy residency, this misunderstanding emerged as one of the major reasons prospective participants were confused. Let me be very clear on this. Primary care physical therapy is not only for underserved areas. A physical therapist in Manhattan, a physical therapist in Los Angeles, a physical therapist in Paducah, Kentucky, for that matter, can be a primary care physical therapist. A physical therapist who works in a hospital, a physical therapist who works in a private practice, a physical therapist who works for the military. Any type of physical therapist can be a primary care physical therapist. So, primary care physical therapy can unquestionably provide enormous benefits to any type of community, especially, of course, in areas where patients may have limited access to physicians. Of course, there is an added benefit to have a physical therapist there who is trained in primary care physical therapy and who is board certified in primary care physical therapy. But primary care physical therapy is not only for those underserved areas. It is just as relevant in a major metropolitan area. Patients in large cities also experience delays in care. They experience fragmented services. They are often sent from one provider to another without a clear clinical pathway. They may receive unnecessary imaging, unnecessary specialist visits, or treatment that does not address the actual source of their condition. But primary care physical therapists can help the patients navigate that process more efficiently. The therapist can determine whether physical therapy is appropriate. The therapist can identify when further investigation is necessary. the therapist can help initiate the correct referral. And when the patient is appropriate for physical therapy, well, patient treatment can begin without unnecessary delay. Primary care PT is not defined by the number of doctors within a particular zip code. It is defined by the clinical preparedness of the physical therapists. Primary care physical therapy is not limited to a specific type of practice. It's not limited to private practice. It's not limited to hospitals, to academic institutions, or to outpatient orthopedists. A physical therapist may practice in home health, rehabilitation, sports medicine, pediatrics, geriatrics, occupational medicine, any type of physical therapy specialty. And that therapist can be a primary care physical therapist. The setting may change, but the fundamental questions remain the same. Can you examine the patient comprehensively? Can you recognize when the presentation is not consistent with a routine physical therapy condition? Can you identify when additional medical evaluation is necessary? Can you communicate your findings effectively? Can you make an appropriate referral? Can you help the patient move through the healthcare system safely and effectively and efficiently, of course? Those abilities are valuable in every physical therapy setting. That is why primary care physical therapy should not be presented as an opportunity for a limited number of therapists. It is a professional development opportunity for the entire physical therapy profession. And why advanced education is necessary? Well, let's put it this way. Physical therapists receive extensive professional education, especially with the evolution of DPT. However, healthcare continues to become more complex. Many clinicians may have studied pathology, pharmacology, lab values, diagnostic imaging, cardiopulmonary disease, neurology, and medical screening during their professional education. But the important question is not whether they once studied these subjects. The important question is whether they can apply that knowledge confidently when a patient is sitting in front of them. Can the therapist recognize the significance of an abnormal laboratory value? Can the therapist identify symptoms that they may be related to a medication? Can the therapist differentiate a mechanical presentation from a vascular, neurological, or systemic presentation? Can the therapist determine whether diagnostic testing is appropriate and what? Can the therapist integrate imaging findings with a history and physical examination? Can the therapist explain and defend the clinical decision to treat, refer, or request further investigation? And this is why structured primary care training is so important. It refreshes existing knowledge, it expands the clinician's medical understanding, and most importantly, it teaches the therapist how to integrate that knowledge into real clinical decision making. Well, my friends, through hands-on diagnostics, physical therapists have the opportunity to participate in a structured primary care physical therapy residency. The purpose of the residency is not merely to give participants another certificate. The purpose of the residency is to develop a more complete physical therapist. The residency is designed to strengthen the therapist's ability to perform medical screening, differential diagnosis, clinical reasoning, examination, referral, interprofessional communication, and appropriate integration of diagnostic information. It prepares clinicians to evaluate the patient beyond the obvious musculoskeletal complaint. It also creates a pathway for therapists who want to pursue future board certification in primary care physical therapy to be able to do so. Board certification does provide professional recognition. But the greatest value of the residency begins long before a certification examination. The value is in becoming a therapist who sees more, becoming a therapist who understands more, a therapist who asks better questions, a therapist who makes stronger clinical decisions, and a therapist who creates greater value for the patient, the employer, and the healthcare system. Now, let us connect this to the central theme of this podcast, which is where clinical success meets financial freedom. So, advanced clinical capabilities can lead to greater professional opportunities. A therapist who develops primary care skills may become more valuable to a private practice, to a hospital, to the healthcare system, to a physician group, to an employer based clinic, or to a multidisciplinary organization. That therapist may be positioned for clinical leadership, advanced practice roles, mentorship responsibilities, residency faculty positions, diagnostic practice opportunities, program development, interprofessional care models, and potentially a higher compensation. And you know what? We should not be uncomfortable discussing compensation. Education requires an investment. Advanced training requires effort. Greater responsibility carries greater value. When a physical therapist expands their knowledge, improves patient safety, strengthens clinical outcomes, supports other team members, and helps an organization develop new services, that therapist should have the opportunity to advance financially. Clinical advancement and financial advancement should not be viewed as opposing concepts. In a healthy profession, they should support one another. A more capable therapist can create more value. An increased value can create greater career and income opportunities. On another note, primary care physical therapy also provides significant benefits to the private practice owner. The physical therapy marketplace is crowded. Many practices describe themselves using the same words: quality care, individualized treatment, hands-on treatment, one-on-one attention, state of, what is that called? State of art. Yeah, you see, I'm even missing my words now. Why? Because these are cliche statements. Well, those claims are important, but they no longer create meaningful differentiation by themselves. Every website you're going to open, they use these words. A practice with primary care trained physical therapists can communicate something much stronger. We are not simply a destination for treatment after someone else determines what is wrong. We are prepared to evaluate you, determine whether physical therapy is appropriate, identify when additional investigation may be needed, and help guide you toward the correct next step. And that is a different position in the healthcare market. It changes how patients see the practice. It changes how physicians see the practice. It changes how employers and payers may see the practice. And it changes how physical therapists working within the organization see their own professional role. A practice employing primary care trained physical therapists may experience several clinical benefits. The quality of patient screening can improve. The risk of treating inappropriate patients may decrease. Referral decisions can become more accurate and timely. Communication with physicians and specialists can improve. Direct access patients may be managed with greater confidence. The practice may develop more consistent clinical standards. Primary care trained clinicians can also become internal resources for the rest of the staff. They can help less experienced therapists think through complex cases. They can assist with clinical decision making. They can help establish referral protocols. They can lead case review meetings. They can improve the clinical culture of the entire organization. A practice does not necessarily need every physical therapist to enter residency training simultaneously. Training one or two key clinicians can begin to elevate the performance of the entire team. And you know what? For the practice, there are also important financial implications. A practice that is prepared to receive patients directly can establish the patient relationship earlier. A practice that performs stronger screening can reduce risk and avoid inappropriate treatment. A practice that builds stronger relationships with physicians and other providers may generate additional referrals. A practice that develops advanced clinical services may create new revenue opportunities. A practice that provides meaningful career pathways may improve therapist recruitment and retention. And a practice that becomes recognized, a sophisticated first contact provider, can distinguish itself from lower cost, commodity based competitors. So, my friends, primary care physical therapy can support practice differentiation, patient acquisition, direct access growth, improved referral relationships, staff development, recruitment and retention, advanced service lines, diagnostic integration, value based care opportunities, and long term organizational stability. These benefits do not appear automatically simply because a practice uses the term primary care. The practice must develop the actual clinical capability or capabilities. But when those capabilities are present, the practice can build a stronger clinical model and a stronger business model at the same time. And you know what? One of the greatest challenges facing, especially private practice today, is recruiting and retaining talented physical therapists. Why? Because therapists do not want only a job, they want a career. They want opportunities to learn. They want mentorship. They want leadership pathways. They want to develop advanced skills. And they want to know that they will be more professionally capable 5 years from now than they are today. A private practice that offers a pathway into primary care training, residency education, diagnostics, leadership, and board certification becomes much more attractive to ambitious clinicians. Instead of competing only through salary, the practice can compete through opportunity. And when opportunity and compensation are appropriately aligned, the practice becomes much more likely to retain its best people. And that is a major financial benefit. Turnover is expensive. Recruitment is expensive. Lost opportunity, that's expensive. A strong professional development pathway can reduce those costs while improving the quality of care. And let me say now something about primary care PT and the future of reimbursement. Well, payment in healthcare increasingly depends upon value. Payers, employers, health systems, and patients want better outcomes. They want fewer, I should say, unnecessary services, faster access, and more efficient care pathways. And primary care trained physical therapists can contribute directly to those goals. They can help patients enter the appropriate level of care earlier. They can identify when physical therapy is not appropriate. They can reduce unnecessary delays. They can help prevent inappropriate utilization. They can improve communication across providers. They can support earlier conservative management when physical therapy is appropriate. And this is how physical therapists demonstrate value beyond the number of treatment visits they provide. For too long, the profession has frequently allowed its financial identity to be determined by units, by visits, and declining reimbursement schedules. But primary care physical therapy allows us to tell a different story. The physical therapist is not merely providing a treatment procedure. The physical therapist is evaluating risk, directing care, improving access, coordinating services, and helping the healthcare system use its resources more effectively. And that is a much stronger value proposition. And stronger value propositions create the foundation for stronger payment models. And what is the question every physical therapist should ask? Every physical therapist should ask, am I prepared to be the first healthcare professional this patient sees? Not simply, can I treat this patient's knee? Can I mobilize this patient's spine? Can I provide an exercise program? No. But can I recognize when this is not a knee problem? Can I identify when the back pain may represent something more serious? Can I recognize when weakness is not caused by deconditioning? Can I recognize when dizziness requires medical investigation? Can I determine whether this patient belongs in physical therapy today? That is the level of responsibility that comes with being a true first contact provider. And the question every practice owner should ask, he should ask a similar question. Is my clinical team truly prepared for direct access? We have it, but are we prepared? Can my therapist consistently recognize red flags? Can they identify systemic conditions that may present as musculoskeletal pain? Can they explain why a patient should be treated or referred? Can they communicate confidently with physicians? Can they document their clinical reasoning? Can they guide the patient appropriately when a physical therapy is not the answer? If the answer is inconsistent, primary care development is not simply an educational option. It is a strategic need. Because the practices that develop these capabilities will be better positioned for the future than practices that continue functioning only as treatment destinations. And here are 5 actions for you to take. These are, and I'm going to leave you with these 5 practical actions. First, stop thinking of primary care PT as a rural or underserved area model. Those communities need primary care physical therapists, but so does every other community. Second, evaluate your current clinical readiness. Assess your knowledge of medical screening, medications, laboratory values, imaging, systemic pathology, red flags, and referral decision making. Third, review your state practice act carefully. Understand what is permitted, but do not impose limitations on yourself simply because the phrase primary care PT does not appear in the statute of your practice act. That's a fallacy. Fourth, seek structured education. Reading occasional articles is not the same as developing a systemic framework, or I should say a systematic framework for first contact practice. And fifth, think strategically. Consider what advanced primary care capabilities could mean for your career, your compensation, your practice, your staff, your patients, and your long-term professional position. So, in closing, primary care physical therapy is not reserved for remote areas. It is not restricted to one setting. It is not available only to a limited number of therapists. And it does not require physical therapists to abandon their professional identity. It requires us to fully develop that identity. As I said, direct access has opened the door. Primary care education prepares us to walk through that door responsibly. The future of physical therapy will not be secured simply by asking the healthcare system to recognize us differently. It will be secured by developing the knowledge, judgment, and capabilities that justify greater recognition. When physical therapists become stronger, first contact providers, patients benefit. When patients benefit, practices become stronger. When practices become stronger, careers expand. And when clinical value expands, opportunities for financial advancement expand with it. That is exactly where clinical success meets financial freedom. So, my friends, to learn about primary care physical therapy, the primary care physical therapy residency, and the pathway toward future board certification, please visit primarycarept.com. And if you would like to speak with me directly about how primary care PT, diagnostics, or advanced clinical training may fit into your career or your practice, you can schedule a meeting with me at meetwithdimi.com. I open a couple of spots every week for people who need to meet with me, meetwithdimi.com. And please remember to subscribe to Your Practice, Your Money so you do not miss future episodes. And please forward this episode to your friends, colleagues, practice owners, and physical therapists who need to hear this message. Because the future of our profession depends on more physical therapists understanding the opportunities that are in front of us. So thank you for joining me today. I'm Dr. Dimitrios Kostopoulos. I will see you next time. Until then, keep creating clinical success and financial freedom. Take care.